administration, follow-up care, the cost factor. So this instruction course basically aims at alleviating all those doubts and to be of help to those who wish to incorporate tPA in the retina practice hassle-free. We'll also be discussing use of tPA in non-submacular hemorrhagic cases like suprachoroidal bleeds and epiretinal membranes. For this IC, I would like to invite the co-instructors to the podium. Dr. Sangeet Mittal will be joining us late because he has some other commitments also at the same time. So I would like to invite Dr. Anirudh Mehti to come. Okay, sir. Then Dr. Subijay Sinha is with us. Dr. Devesh Kumawat. So Dr. Devesh Kumawat is assistant professor at RP Center AIMS, working in the Retina UV and ROP department. Dr. Subijay Sinha was an ex trainee at RP Center, and he was at Sushrut for a considerable amount of time, and currently he is the director of Drishtideep Eye Institute, Dankuni, with having his own private practice in Calcutta. I would like to invite Dr. Anirudh Mehti also, and I would like to introduce him. So he is the director of Global Eye Hospital and the honorary treasurer of Ophthalmic Society of West Bengal, and he's the managing committee member of AIOS. Dr. Sangeet Mittal, he needs no introduction because he has to his credits a lot of awards vis-a-vis his videos. He is the director of Vitreoretina services at Thind Eye Hospital, Jalandhar. And I am Dr. Bibhuti Kashyap. I am the deputy director of Kashyap Memorial Eye Hospital, Ranchi, and I'm heading the Vitreoretina UV and ROP services at that hospital. So without further ado, I would be starting the IC. The first talk would be mine, which will be about introduction, types, logistics, and my scenarios of tPA use. So good afternoon, everybody. My topic for today is Tissue Plasminogen Activator in retinal practice. So tPA, or Tissue Plasminogen Activator, is a naturally occurring serine protease. The major enzymatic action of tPA is the conversion of plasminogen into plasmin, an active serine protease that hydrolyzes fibrin. Fibrin forms a ternary complex with tPA and plasminogen, which increases the rate of plasminogen activator several hundred folds. And this is a pictographic representation of how the tPA works. The commercially available tissue plasminogen activator to our availability is alteplase, tenecteplase, and reteplase. There have been multiple papers published regarding the use of tPA in the eye, starting from as early as 2005. Some of them have used it in submacular hemorrhage, combining with subretinal air, or combining it with a cocktail of submacular air and anti-VEGF. One of the studies came from RP Center early on, 8 years back. So it's pretty much well established that what are the usual indications of tPA, but there still exists a tendency to avoid the use of tPA because of two major rate limiting factors. First is the cost factor, and second is the steep learning curve factor. And this instruction course tends to alleviate sort of those two factors to help you incorporate tPA in a much better and a hassle-free way. So to understand that, what we have to understand is that what are the tPAs available currently with us. So amongst the 4 tPAs, alteplase, tenecteplase, and reteplase are the available modalities, amongst which tenecteplase is the highest, it has the highest selectivity, and reteplase is a relatively lesser selective alternative of tPA. But when we are dealing with a small amount of hemorrhage, such as a submacular hemorrhage, which in comparison to a blood clot in the vessels is a small amount, no matter how massive it is, then this specificity doesn't matter. So a 10 hectaplays would be expensive to use when we are practically throwing away 99.99% of the drug. So a better alternative is to use a retaplays. Now retaplays comes in a box which has 2 vials, so it can also allow you for a sequential using in 2 different patients from the same box that you have purchased. It will cut down your cost to literally 1/3 or 1/4 of what 10 hectaplays is all about. I'll be discussing that later. So the routes of tPA administration is intravitreal. It is used usually in submacular bleed in conjunction with a pneumatic displacement with a dosage of 50 to 100 micrograms per 0.1 ml. The rationale is that it increases the chances at resolution by inducing clot dissolution, and it reduces the adhesion of the clot. So when we go through the papers that have been published on analyzing the forces acting upon a submacular hemorrhage, what we know is that the buoyancy and the gravity, they cancel each other out, and that's how the submacular hemorrhage, it is stationary. So in a non-vitrectomized eye, when we put gas, then the interface changes to that of a blood gas interface, and hence the buoyancy caused by it is lesser than the gravity. So in a non-vitrectomized eye, we have to position the eye such that the interface is that of a gas blood interface rather than that of a gas than that of a blood vitreous interface, and that is how the buoyancy force becomes much lesser and the blood gravitates down. But then for this to happen, the clot has to be mobile, adhesion prevention has to happen, and the clot has to liquefy, because the liquefied clot has a slightly greater density than that of intraocular fluid. So here is where the role of tPA comes in. Utilizing this method of treatment, I treated a 75-year-old male with a submacular bleed secondary to a PCV with blunt trauma. And this was the preoperative fundus picture. And the OCT showed something like this. The plan was intravitreal tPA with brolucizumab with a C3F8 gas tamponade, followed by 2 monthly intravitreal brolucizumab under under TA. And post first dose, there was near total resolution of blood as well as edema. And post third dose, the OCT cleared off to give a very clear near normal anatomical structure with a BCVA of 6/9 parts from a hand movements close to face. And this was the fundus picture at the end of 3 months. Now, intravitreal use is a relatively simpler route of administration, but the outcome, of course, is unpredictable due to multifactorial causes that also have been published with vis-a-vis its penetrability, etc. So a more specific use is a subretinal use, and this is where the entire roadblocks come into play, because any given day this has a much more selective, specific, and a very nearly 100% rate of acting. The rationale being it bypasses the retinal barrier and acts on the clot directly, and secondarily the mechanical displacement of heme away from the fovea within the subretinal drug bubble also helps to clear out the blood away from the fovea. The dosage that I use is 25-30 micrograms per 0.1 ml. The entire concern of this method is a controlled subretinal microdose delivery and the cost factor. These are the 2 main reasons why we see multiple papers which are trying to obviate the need of use of either use of tPA or the use of a subretinal tPA. So the need of the hour is to basically have a risk-free flattening of a seemingly steep learning curve, thereby significantly improving the chances of a good anatomical and functional outcome of a frequently encountered problem. And this is why I employ this method. This is a microdose injector made by Med1, no financial interest. And I use Med1's 38 gauge straight tip needle, a cannula. This is fit to the silicon oil plunger of a Constellation machine, and with this I put the infusion pressure at 10 to 12, the injection pressure to 10 to 12. With this what I do is I transfer the control of the subretinal bubbles formation speed from my hand to the foot pedal, and that is also not having a learning curve of how fast I press the pedal or how slow I press the pedal. Once I put it to 12 and I have a full throttle on the foot pedal, even then with the full throttle, this is the speed, the rate at which the towel is getting wet. This is the speed at which the tPA gets injected with a full throttle of foot pedal with a 10 to 12 pressure. So when I employ this, the entire learning curve goes for a toss. And regarding the cost factor, if we purchase a 10 hectaplays, there are two packages for it, 40 mg and 30 mg. Considering we're using at max 100 micrograms, 30 mg will work fine, but even 30 mg will cost you between 20 to 25,000 rupees. But a reti will come in for 15,000 rupees. It has two vials, so the per vial will cost you 7.5 thousand rupees, and a microdose injector will cost you around 2,000 rupees. So even if you don't reuse it, firstly it is reusable if you will ETO it, but even if you do not reuse it, even then per injection with the cannula will and the microdose injector is reusable. So even with the non-reusable things, with a fresh vial, the recurring cost would just be 9.5 thousand rupees. So it eliminates the cost factor, and it also eliminates the learning curve. So my case 2 is to show just that. This is a case of a post-traumatic vitreous bleed with a submacular bleed. So after doing a core and a peripheral, I went ahead with a 360-degree laser, and then with a 38 gauge, just pierce it, just tilt it a bit horizontal, and press the foot pedal full throttle. It will be a very slow, gradual formation, no risk of rips or hole formation, etc. And just do a fax with gas, and you're done. No need to put submacular anti-VEGF, because anti-VEGF can be put intravitreally also after a PPV, works just fine. So post third week, this was the post-op. The bleed had cleared, showed choroidal scarring due to trauma. Pre-operative OCT, which was having a finger counting close to face, improved to an OCT that looked like this. Slight ISOS discontinuity, but I was happy with the anatomical restoration of it. BCVA improved to a 5/60. We can also use it intraoperatively, wherein in this case, after a segmental buckle, in a case of RD, I did not feel the need to. Okay, now there are two things to it. A, I didn't need to create a retinotomy or a break to drain it, and also I don't have any threshold of treating the submacular bleed, because all the thresholds that I have read about in the published articles, I believe that if given a choice and if the risk-free flattening is there of the learning curve, I would say that for a better chance at anatomical recovery, if given a choice of risk-free intervention, I would go for a submacular injection even in the smallest of cases. So in this case, after the liquefaction of the blood has settled down inferiorly, intraoperatively. There is no retinotomy made for the evacuation of the blood. And then laser and oil injection is done as usual. And the oil was injected, yeah. So 6 weeks follow-up, BCVA was 3/60, IOP controlled, adequate oil fill. Post-SOR BCVA was 6/60 with controlled IOP on anti-glaucoma. So a few more examples, post-traumatic submacular bleed. In this also we know that we see a lot of videos about draining a large submacular bleed by making an adjacent retinectomy or a large iatrogenic GRT to evacuate the bleed. Now it's not this bleed is not that large a bleed, but I used the tPA in this case to try and see if something called as a subretinal lavage that I think will be the way forward. In this case, what I did was there was an inferotemporal retinotomy, a small retinotomy, the way we make to drain the SRF was made, and then a tPA was injected superiorly. It liquefied the blood, and the blood, whatever excess blood had to be evacuated, it evacuated through the retinotomy, and the residual blood, if was not coming out, settled inferiorly. So no big break was formed. Laser it, leave it in gas, and the recovery was just fine. The patient improved to a 6/36. So this is something that I did. I call it the subretinal tPA lavage. This is a case of a post-traumatic subpapillomacular bundle bleed, where again we see the bleed amount is very small, but that's what I said, like if I remove the learning curve of it, I would be tempted to intervene surgically for a rapid resolution, even in small bleeds if it is involving a critical anatomical landmark like a papillomacular bundle. In this case, the vision improved from a finger counting to a 624 parts at 1 month. This is again a CNVM, regular CNVM case with a submacular bleed treated with subretinal tPA. 1 month post-op revealed 6 by 18 parts. Now this was a new on old submacular bleed. In this case, there's a post-traumatic case with a post-traumatic bleed, not treated, formed a choroidal rupture was there underneath, formed a secondary CNVM, re-bled again. In this case, the secondary rationale where we inject and the bleed gets the clotted blood and the fresh bleed also gets mechanically displaced, comes into picture, and we also achieved a very satisfactory anatomical improvement with this modality. Now there's a non-hemorrhagic use that I stumbled upon accidentally, where in a case of when I used an intravitreal tPA and the blood did not resolve when I went in for a PPV, I found the vitreous to be liquefied enough and the PVD to have happened. So this led me to think, because of the proteolytic action, can I use this in taut ERMs? Now there is, it has to be pretty subjective, of course, I know, but just going by the look of it, if I see an ERM like this, I would think it to be taut with a broad attachment with a very broad lift up. In these cases, what I do is I inject the tPA 24 hours prior to planning an ERM removal. And this is an unedited video just to show the ease and the speed and the lift of ERM. This is how tight the ERM looked, but when I tried to pull it off without almost any traction on the retina, it simply lifted off like this from the macula. So in my thought process, I think that this can also be a future of tPA use, where we can use it in non-hemorrhagic cases such as epiretinal membrane, taut epiretinal membrane. As to, of course, studies have to be done to define which is a taut ERM, how do you say it's a taut ERM, etc., etc. But just by clinical observation, if we feel like, we can always go in for a rationale of giving a preoperative tPA followed by an ERM removal. Thank you. Any questions from anybody? Yes, sir.
How many cases you have done in this epiretinal membrane, extensive epiretinal membrane?
So currently I have done seven cases. Yeah.
Is there any publication or literature support?
Sir, there has been no literature support for this. That is why it made me think out of the box. The literature support has been of a non-enzymatic vitriolysis and all of that, which has been tried, tested, and not worked. But there again, sir, this was a serendipity when I did it, and the intravitreal tPA field, as I said, I found the vitreous to be pretty liquefied. So that's where I thought in the lines of probably it may loosen up. It may not cause a complete ERM removal. So I'm not having it as a non-surgical alternative. It is a pre-surgical, adjunct, yeah, to ease the removal of ERM. So it basically acts like an alcohol for a PRK. Like what we do for a PRK, we put alcohol in the epithelium, just comes off. This may act like a tPA as an alcohol for tPA acting as a alcohol for ERM.
The ERM for aneurysm for lab, whether the structurally it is changing, and in some patients not
Have you done the
using
OCT after giving PRTPA?
Sir?
Have you done the pre-injection and post-injection OCT?
So OCT didn't change. It did not have a detachment. The ERM did not get resolved. No, sir, no separation. Sir, that is what exactly I was talking about. Like that analysis is just been 7 cases old that I have done this, and I have not evaluated it in that extent, but that is the future line of thought process that is going on.
If you can wait for a week and see if it separates, because we have operated the lens here, so maybe.
Probably, yes. It's an open vista. There is no research done on these lines, and it can have it. This can serve as, and maybe all of us can collaborate and get a paper. So Dr. Boral, we can do it. So I now invite Dr. Anirudh Mathi to give his talk. I would request Dr. Devesh to just take over the emceeing of this IC just for 10 minutes, because I have another session of 2 minutes to win. So I'll just come back in 10 minutes. Till then, just sir, you and all the participants, if you can just carry forward.
Thank you, Bibhuti. for this opportunity. Well, I will be, already Dr. Bibhuti has described all about tPA. So I will go the opposite way, like the main indication is submacular hemorrhage. So if we see that the reasons for the submacular hemorrhage, the CNVM, PCV and RAM, these are the main causes where the submacular hemorrhage occurs. And the PCV is the most commonly associated with a large submacular hemorrhage. And why is it so important to treat so early? Because it causes an irreversible retinal injury as early as 24 hours. So more rapidly it has been diagnosed and early intervention is done, the results are better. Because it has been seen that there is a gross deterioration of vision if it is left untreated. And definitely we need to treat the underlying cause as well. So we are not going to do the diagnosis. Treatment options are many. It's submacular hemorrhage. Sometimes it can be treated with only anti-VEGF also. Pneumatic displacement with anti-VEGF, without anti-VEGF, only the C3F8 and anti-VEGF, and tPA with anti-VEGF, that is an option. And obviously the last is subretinal tPA, intravitreal tPA and subretinal tPA. So we will go one by one case scenario. This is like, as I was mentioning, some hemorrhage might not be that large and the thickness of blood may be less than 450 microns. In those cases, actually, we can try with the anti-VEGF as well. Here in this case, you can see the presenting visual acuity was finger counting 2 feet. And with anti-VEGF loading dose, it improved to 660. Now, the next scenario is like, it's a RAM bleeding. And it was treated with pneumatic displacement RTPA. Anti-VEGF I had given because there was a macular edema. We might not give anti-VEGF for a RAM. And what happened is, following the intravitreal tPA, there was a breakthrough hemorrhage, which can happen. We need to, when we are giving RTPA either intravitreally or subretinally, we need to counsel the patient that this, you might have a breakthrough bleeding. This is pretty common, and the patient should be counseled before proceeding with the operation. So once this breakthrough bleeding happened, we had to take for the vitrectomy, and I will just forward it. You can see the dense hemorrhage is there. Oh, sorry. You can see the gas was still there. The tampon ad was still there. If you don't counsel the patient will go to other surgeon. But the good part is sometimes the breakthrough bleeding, especially in RAM, it's good. In a sense, you can actually take out all the blood, and the blood becomes more approachable and can be removed easily. And this patient actually did pretty good after the vitrectomy. Now we can see the retina, and that's the part. A small part is still left behind, but I think with time this goes off. So this was after the surgery, and we did a little bit of laser as well. That is the spot where the RAM bleeding happened, and the patient actually improved to 612, and a pretty happy patient. Now this is a case where the submacular hemorrhage, you can say it's quite a large one, and seeing the OCT, it can be diagnosed as this is a case of a PCV, multiple PEDs, notched PEDs. So we planned for intravitreal tPA, pneumatic displacements with anti-VEGF, considering this as a case of a PCV. And this happened to be one of the leading cardiologist's wives, so I was a little bit apprehensive in taking this case for the subretinal tPA. So let's see with the intravitreal tPA, it's a less intervention will be required. The vision was 660, but this patient actually did pretty well. After 3 weeks, you can see the hemorrhage has subsided pretty well, and the vision has improved to 624. After 2 months, obviously we had given the loading dose of anti-VEGF following the surgery as well. And after 2 months, it improved to 6.9, and 3 months it was actually 6.6. The patient is pretty happy. So not necessarily at all the time we have to go for subretinal tPA. Intravitreal tPA does pretty well in many cases. Obviously, if it is a very large one, then we have to plan with a subretinal tPA. Like this case, there was no other option than subretinal tPA. You can see the huge hemorrhage, subretinal hemorrhage. Generally, the dictum is it's more than 4 disc diameter. We go for the subretinal tPA, but it can vary, and it's actually on the discretion of the surgeon's discretion whether they will go for a subretinal tPA or an intravitreal tPA. The good part, this patient had come pretty early. The reason I'm showing this that anything can happen after subretinal tPA, because many cases they respond pretty good, but some cases can have a lot of complications. So once we are through with the PVD and give tPA, tPA was injected with the gas tamponade. Now this patient was a outstation patient. He went back to his hometown, and then when he came almost after 3 months. So what we saw is the subretinal hemorrhage is almost subsided entirely, but he presented with an retinal detachment inferiorly. Quite a stiff one actually. This was the scenario. You can see there was no hemorrhage, almost the entire hemorrhage has gone. Except for the posterior pole, you can see a little bit of organized hemorrhage. But the retina was stiff, inferior stiff retinal detachment. Maybe the hemorrhage has subsided, but there was a huge subretinal hemorrhage. So we had to take this case and now treat it as an inferior RD, and I had to do a retinectomy. It was absolutely stiff over there. But at least this patient, when it came with a huge subretinal hemorrhage, the vision was almost, PL vision was there, perceptual light was there, but at least we could give some ambulatory vision after this settling the retina. And did a laser and did silicon oil POCL exchange. Now, coming to the last case, this was a quite an old submacular hemorrhage. Patient presented pretty late. We thought, okay, let us try. Patient was given an option that generally if it is late, the results doesn't come well, but we can try. So the patient was agreed to it, and we did a vitrectomy for this patient. You can see the little bit of fresh hemorrhage, a little bit of hemorrhage is still, it is not organized, but the middle part is already organized. In this case, we obviously didn't do within first 2 weeks, which has been generally advocated that you should take as early as possible, preferably within first 2 weeks. Now, as there was a large hemorrhage and an organized one, we had given in a multiple place. Yes, if it is, yeah. Now, after this procedure, now this is 3 weeks after the PPV. I thought the macula has already will be there, but after 3 weeks after PPV, pneumatic displacement and subretinal RTPA and anti-VEGF, there was, you can see the size of the hemorrhage is reduced and the vision is improved a bit. After 6 weeks, it improved to 5 feet of vision. And after 3 months, actually, the hemorrhage totally gone. The subretinal organized hemorrhage are totally gone. But as expected, there was a macular hole formation. But this is like a late presentation of the macular hole. So there was further diminution of vision when the macular hole was formed. So we had to take this case for it's already vitrectomized eye. Now we had to treat the macular hole. Now again, you can see there is no hemorrhage. Now all the organized hemorrhage has also gone. And did an inverse peel technique. You can see the hole is quite large. So I'm almost done. So this was the result after the macular hole surgery. At least the vision, what it lost due to the macular hole formation, it went back to 660. And now you can see there is no subretinal hemorrhage. So this is also one complication of the subretinal tPA. There can be macular hole formation, breakthrough hemorrhage. Already we have shown one case. So treating the underlying pathology is very important. Whatever the cause is, if it is a RAM, you need to do the laser. PC, we need to treat with anti-VEGF injections. So this needs to be taken care. And to conclude, yes, as a general approach to submacular hemorrhage treatment, pneumatic displacement can be combined with intravitreal RTPA if there is no contraindication. But as I was discussing previously, like anti-VEGF is also, the monotherapy is also an option. So although some macular hemorrhage can be challenging to manage, reasonable visual outcome can be achieved with timely and appropriate intervention. Thank you.
May I say something?
Yeah.
Hello, Dr. Maiti. Basically, the macular hole formation happened to your case.
It was very close to.
Yes, basically in both of your cases, you have given injection within the arcade.
No, the first case.
First case I'm telling you, the distribution of hemorrhage. Another thing, one thing is size of the hemorrhage. Number 2 is duration of hemorrhage. Number 3, the distribution of hemorrhage. 3 things are important. People are talking about the size of the hemorrhage as well
And
as
thickness.
duration. And thickness, some says yes or some says no. But I should say distribution is also very important. In your first case, the ideal case for giving subretinal tPA, but not within the arcade. You could have given just beneath the inferior arcade. And second thing also, second case, you are lucky that macular hole formation not happened in your first case. But in your second case, it was very tricky situation because partially organized, partially fresh. So that in that situation, lot of addition might be there. So the tPA immediately and the force, there is sudden increase in submacular
But that was the
volume.
only area where the hemorrhage was there.
Submacular volume, sudden increase in submacular volume, and there was organized blood that was very there is lot of discrepancy between the adherence.
It was a mixture between organized and fresh bleeding.
Fresh hemorrhage.
No,
So
I
that
had
will-
expected this whole will happen the next post-operative day, but
Yes.
fortunately it happened after 3
Because
months.
of the presence of blood, it was giving some
Maybe
kind of tamponade.
it didn't
Yes.
happen.
Yes. But when you saw that some subaqueous hemorrhage is there, so you just place your soft tip cannula over the hole and try to aspirate little bit of fluid.
That
so
was
that
organized, no?
no, that means organized. Okay, but you are not aspirating out the tPA, but you are just closing the margin of the macro hole because you are sure, but you have seen the blowout has happened. So at that time, just you don't
With the-
wait
with
for the
the-
macro
with
formation in the post-op period. Just because it is my practical experience, in my one of my case, I just did only just apposition of the whole margin that will close the hole, because you are giving the gas tamponade and soft tip cannula, and you are maintaining the prone position, the hole will be closed. The blood will be vanished and hole will be closed.
The hole didn't form actually. They formed pretty late.
Pretty late, but the scan line was not going through the fovea.
No, we actually did that.
If you are doing the six raster scan,
तो raster ही-
yes, sir, it is not that uncommon, sir. It is
The problem happens if
at
it is a
least,
large
one or two
hemorrhage, we can
cases per-
put it
if
in
you are
the
especially
side
keeping
away
the
from the
within the arcade.
fovea.
it's better to avoid go as far as from the fovea as possible.
But in cases where there is in the concentrate in the posterior pole, you can't help it. Na?
Yes, but still you have to choose the area because that's why we are choosing in the significant more than
Yeah.
4 dix diameter hemorrhage should be treated
Next,
by subacute
I'd
hemorrhage.
like to invite Dr. Sangeet.
So good afternoon, everyone. So I'll be presenting tPA where, when, and how I use it. How I use it intravitreal, subretinal, and recently I've tried suprachoroidal in one patient. When I use it, small submacular hemorrhages, I give intravitreal. Then large submacular hemorrhages, hemorrhagic retinal detachments, suprachoroidal hemorrhage, and subsilicon oil pre-retinal hemorrhages. So small submacular hemorrhages you just displace using the intravitreal gas and tPA. This technique attempts to physically displace the submacular hemorrhage out of the fovea using expansile gas faster by liquefaction of the clotted blood using tPA. The dose given is 50 micrograms. The procedure is performed under topical anesthesia and involves an intravitreal injection of 0.3 to 0.4 ml of SF6. Most commonly I use SF6 and sometimes C3F8. A face down positioning is done for 1 to 3 days, and the advantage is that you can do it in OPD and there's a shorter displacement time. So this is one of the cases. There was a macroaneurysm which has led to the hemorrhage in all the 3 layers, and this was given this intravitreal tPA and gas was given post-operatively. Very fast. The action occurs very fast in this type of small submacular hemorrhages. I was able to displace of the hemorrhage, and this is another patient. This was, in fact, was the first case which I had treated of submacular hemorrhage with intravitreal injection and tPA. So large submacular hemorrhage vitrectomy with subretinal tPA. You use the small 41 gauge macro cannula nowadays, and this is how I go about it. So this was a large submacular hemorrhage.
85-year male presented with complaints of sudden decrease of vision for 10 days. He was diagnosed as massive subretinal hemorrhage secondary to IPCB. Incidentally, he had undergone retinal surgery for vitreous hemorrhage, retinal detachment, and subretinal hemorrhage in other eye about 3 months ago. We plan to do vitrectomy with subretinal injection of tPA in this eye. After completing vitrectomy without base excision, ICG-assisted ILM cleaning was done. tPA in the dose of 25 micrograms in 0.1 ml was injected subretinal using a 41 gauge micro cannula. Subretinal bleb was raised slowly with the help of a self-made subretinal fluid injector. The injection was done at 2 different sites. Fluid air exchange was done. SF6 gas was used as tamponade. Patient was advised prone positioning postoperatively. 3 weeks post-op, significant reduction in subretinal hemorrhage was seen. 6 weeks post-op, subretinal hemorrhage had resolved and visual acuity improved to 6/9.
And what we were discussing in the last case, this is a common complication that I.
Macular blowout. This is mainly due to the uncontrolled forceful injection by the assistant who is pushing the plunger while the surgeon holds the syringe. This also leads to shaking of surgeon's hand while injection. To overcome this, an automated subretinal injector can be made in the OR. A 1 ml tuberculin syringe is cut at 0.5 ml mark. Plunger is cut with a length of 0.1 ml longer than syringe. A small hole is made into the rubber of the 10 ml syringe. The cut tuberculin syringe is then fitted into the rubber. A hole is then drilled in the 10 milliliter syringe and its hub is removed. Tuberculin syringe prepared earlier is then fitted in this 10 ml syringe as shown. This apparatus is then connected to the PFI system on vitrectomy machine. The drug is filled into the syringe from top and microcannula is connected. The speed of the injection can be foot controlled. 42-year female presented with macroaneurysm, pre-retinal, sub-ILM and subretinal hemorrhage. 27-gauge vitrectomy was done without base excision. PPT was induced with the help of triamcinolone. Vitrectomy was completed. ILM peeling was done using ICG dye and the sub-ILM blood was washed away. Gauge microcannula connected to the subretinal injector was used to inject tPA in subretinal space. Notice the smooth injection and less shaking of hands in this case. Fluid air exchange is done so that air replaces about 60% of the fluid in vitreous cavity. Air is then exchanged with SF6 gas. The visual acuity improved to 6/12 at 4 weeks post. Common complications.
So this was a case of a large hemorrhagic retinal detachment, and there was no breaks. Only this large submacular hemorrhage secondary to IPCV was seen, and this patient I gave intravitreal tPA 1 day before I took her up for surgery, and next day I drained the hemorrhage externally, not going inside and doing the vitrectomy. And this is the picture on the left side is 1 day post-operative, and I was almost able to drain most of the blood in this eye. Otherwise, I have to go inside, create a large retinectomy, and remove the blood. So this is another option where a tPA can be used. Then for suprachoroidal hemorrhages, this was a 56 years female, 2 weeks post-cataract surgery. A suprachoroidal hemorrhage had occurred intraoperative. The best corrected vision was PLPR accurate. The patient also had a retinal detachment with giant retinal tear, and retina was lying in the pupillary plane. So we can't delay the surgery for more period than this period, 2 weeks. Although 2 weeks is also good enough that the clotted blood liquefies and you will get. But precautionary, I just chose to give a suprachoroidal tPA 24 hours prior to surgery, and then took the patient up for surgery, and this was the surgery that was performed.
Giant retinal tear and PPR underwent vitrectomy 3 weeks after her cataract surgery. Cannula for infusion was placed temporarily. Endo-illuminator was placed inside the cannula. White reflex indicated correct placement of cannula in the vitreous cavity. 4-port vitrectomy with chandelier in infernasal quadrant was started and anterior vitreous was removed. Retina was seen in the iris plane. Subarotemporal cannula was seen to be in suprachoroidal space. Tissue surrounding the cannula was dissected to bring it in vitreous cavity. Vitreous adhesions to iris were removed and anterior vitrectomy completed. Core vitreous was removed to reveal the posterior hyaloid. Triamcinolone assisted induction of PVD was done and vitrectomy with base excision was completed. Subretinal blood was slowly aspirated using silicone tip backflush cannula. Remnants of capsule were peeled and removed. PFCL was used to stabilize posterior retina and ILM was peeled under PFCL. Subretinal bands were peeled to take care of fixed folds. 26-gauge intravenous catheter was inserted in suprachoroidal space to remove the residual hemorrhage. After confirming the tip to be in right phase, the metallic skillet was removed, leaving the plastic cannula behind, and blood was drained out. Retinectomy was done to release all traction on retina. PFCL was used to flatten the retina and 360-degree peripheral barrage laser was done. A direct PFCL silicone oil exchange was done.
So this is the final post-operative pictures of this patient. So I have done only one case in which I have used this suprachoroidal, but I feel it may be sometimes be useful when you can't wait for longer to a time like 2 weeks or 3 weeks in the presence of a retinal detachment or kissing choroidals, which may cause very PVR very soon, rather than if we wait, we may even lose the case at that time. So in those cases, it can be given a try. Then subsilicon oil pre-retinal hemorrhage. Again, I've used in one case, but I did not have a favorable outcome. Actually, I missed that there was still a little bit of detachment present below in that patient. And the clot definitely got lysed, but the blood went subretinal and through the open break which was present. And it also scattered all around and retina could not be settled again. Thank you.
Can I say something?
Sure, sir, please.
Especially submacular hemorrhage, we should not remove the ILM just before giving the subretinal tPA, as subretinal tPA sometimes cause this macular blowout, foveal blowout. So if you have the macular formation post-operative period or during the surgery, you have to sometimes do the inverted ILM flap technique. So if you don't have the ILM at that time, so your macula will not be closed. So that is I think we should preserve that this ILM as just as a
you are
routine
right. The
submacular
only
surgery.
thing is like if this macular blowout occurs and there's a macular hole formation, it is very difficult to remove the ILM at that stage, because sometimes there are air bubbles below and the retina gets raised. It's very difficult actually at that very sitting if you try to do it.
That's yes. That's why.
And in one of those cases,
during surgery, during the foveal blowout, you can just touch your this soft tip cannula just overlaying the macular hole to just oppose the hole margin. So if the fortunately hole is closed, that's good enough. If you are not closing in the postoperative or there is reopening of the macular hole, then you can even do the ILM surgery after the in post-op period after 2 weeks, when the most of the blood has gone, because you should not take the subretinal tPA out from the subretinal space, as it will it will not serve your primary purpose. So tPA ILM, I think it should be preserved routinely. Whatever, sir, what is your?
That's what I was talking, that was it a prophylactic removal or just because it is
so one thing was like if the blood is multi-layered, like there was a sub-ILM blood, then there was an intraretinal hemorrhage, subretinal hemorrhage, as in that macroaneurysm case. Pardon, sir?
In the patient where you
one patient, the earlier one, there was not there. But actually there was such a large submacular hemorrhage, I thought I'd better remove the ILM.
The question was in the first video you showed, where you gave intravitreal tPA. So I would have done only pneumatic displacement and anti-VEGF.
Without the tPA?
Yeah, intravitreal.
Yeah, that's also an option.
Yeah. The other option is that we often forget that these patients, a lot of them are IPCV patients.
Yes, sir.
A lot of them. So post-op, recurrent Eylea injections are required.
Yes, sir.
It's not that because we are doing a mechanical job only. We remove the blood and put the gas or pneumo displacement. But we often forget that these patients do require.
Yeah, the underlying pathology needs to be taken care of post-operatively. That has
I have
to
one patient whom I ultimately injected oil, but with the oil also I keep giving this Eylea injection.
Yes.
I want to say one, like, rather than ILIA, you can choose Brodosivo. Because ILIA is the molecule size is quite large. And if you give this thing, I have done in one study and I've already sent for the publication. I don't know whether it will be published or not if it is accepted by IGO. So the thing is, Brodosivo is the very smallest molecule. And if you are injecting in a vitrectomized area, it will penetrate so faster, it will there will be no time for the washout from the vitreous cavity. So it will go directly into the subretinal space within 6 hours.
And ILM
So-
peeling also helps in that also.
Yes.
Faster
But it's true. But macular formation, if you face in postoperatively, you don't have any tissue to close it. You have to choose the either anterior lens capsule or amniotic graft or autologous retinal graft, all these things. So ILM is the basic thing for to treat macro, to close macro. Yes.
Subretinal tPA, you often require multiple places. You don't inject one
Yes.
place. So at times you have seen, it regurgitates out small fluid, and then you do airflow exchange. It may be more risk coming out. So do you think that we should inject more, or because I have not done it, but in my we often see our videos post-op. So I saw video, it has regurgitated.
Some
Yeah,
amount.
some amount does come.
Yes. Initially, sir, because there is no space, there is potentially where you are injecting, the choroid is totally opposed to retina. And you are not injecting in the area directly under the hemorrhage, you start somewhere away from it. And that is the reason sometimes it just comes out and then it creates a plane and goes inside.
So the idea is to basically create a cleavage plane first. And once there is a cleavage plane formation, you will see less amount of regurgitation and more amount of bubble formation with the kind of injection. As you keep injecting, the bubble formation rate increases, and there you will see a lesser amount of regurgitation, unless and until that bubble is fully stuck with a clot formation. In that case, you may see a slight amount of regurgitation. But even in that case, you may inject slightly more drug, because that regurgitation doesn't negate the dosages that we're trying to put in.
Some people have described, subretinal along with air, along with the air bubble, and along with the Avastin also, everything, cocktail kind of cocktail.
Yes, subretinal cocktail of anti-VEGF, this thing, because in vitrectomy side, most of the anti-VEGF not work, apart from very few options. So you can give even biosimilar ranibizumab also, Avastin also, or the original drug also.
So I have
So
used
these things-
subretinal
Yes,
air.
cocktail, anti-VEGF, subretinal TPA and air.
But
Yes.
sir, in my practice, I've so but in my limited practice of 100 injections that I have done in past 3 years, sir, that I haven't felt the need to make inject air for a cleavage plane generation. I haven't felt the need. I mean, its
No, no,
idea
no,
is
it's not for the generation. Like I was explaining,
yeah.
it is for the when you are giving TPA, the blood will lysed. So lysed blood, that means the RBC will
It'll
be
gravitate.
settled down inferiorly, and if you are injecting subretinal air, that will, due to the buoyancy factor, it will go up, and it will the gravity
It's settled
situation, the
down.
RBC will go down. It will make the foveal area clearer.
Yeah.
So if the distribution of hemorrhage is just beyond the arcade, superior arcade, this is the ideal situation. You just injected the TPA and anti-VEGF, and after some time subretinal and the volume 0.05 cc of this thing. You have to very restricted volume, that TPA, and 0.05 cc of anti-VEGF and 0.03 cc of air,
air.
not more than that.
Yeah,
That is
sir.
the-
Sir, but that is the rationale. If I will ever use a subretinal air, I will use it
Yes,
for.
yes.
But what sir was saying was to create a cleavage plane. So that was what I was telling her. For cleavage plane formation, probably I'll not use an air. But with his rationale, probably I will try to give it a shot to see if there is a better clearance with it.
So I have used subretinal air in patients who are not able to maintain post-op proper positioning. So you just give air and then you exchange it with gas and advise the patient to propped up position you can give.
Propped up position
And
initially.
yeah, and then the problem with subretinal air is, like Dr. Subhendu said, you have to give a very titrated air, because if you give more volume,
More
what happens is the air just cleavages the retina and goes up,
goes up.
and then causes, maybe sometimes it causes retinal detachment
While
also.
the patient is lying down. While the patient is lying down, the air will go up. But when the patient is in the propped up position, again it will come back in the macular position. That I have by the optos, I have done it immediately in post-op period, that peripheral air has again come to the macular area.
When you do the apex, then also the air shifts posterior.
Yes, 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 that's true. Yes, yes, it will accumulate, gravitate. Because of the change in the surface tension, the air will come again into the macular.
So one more problem with subretinal air injection is that the technique that I showed for a controlled dose to eliminate the entire learning curve, I believe, although I haven't tried, but going by the physics and mechanics of it, I believe that injecting the air via that mechanism also will then have a risk of causing a blowout, because I don't know how much of viscosity, how much of air viscosity will be able to prevent a sudden injection rather than just a controlled injection. So that controlled injection, probably I will not be able to achieve with that mechanism that I showed also. But I'll have to
avoid the sudden injection. You should avoid it. That's why I developed one micro VFC tool to just graduated injection of in
Air.
a gradual manner, gradual increase, very gently.
Right, sir.
Thank
Thank
you.
you, sir.
Thank you.
Thank you, Sunil.
I next invite Dr. Subijay Sinha to come to the podium and deliver his talk. He is a director of Drishtideep Eye Institute, Dankuni. He has completed his post-graduation from RP Center and did senior residency in Unit 1 in Retina. Over to you, sir.
Very good afternoon to all, and thanks to Bibhuti for inviting me to present my limited experience of using tPA in various submacular hemorrhages mainly. I haven't used in suprachoroidal hemorrhages and other conditions. So mainly all the videos have shown CNVM, PCV, RAM associated submacular hemorrhages. So I will, there are other options are only anti-VEGF plus gas plus tPA, gas or VR surgery to drain the blood, and the subretinal tPA plus gas. So this is the reti place we are using. The doses are 25 microgram per 0.1 ml of BSS. This is 41 gauge cannula from Med1. So I will show the first case. Where are the videos? उसके साथ था ना videos? इसको बंद करो जरा.
Sir, did you have it embedded in them?
No. In the enter folder I had.
Okay, sir.
Folder कहाँ है? हाँ इसका right. हाँ. This was the case. Had dense vitreous hemorrhage. So and the ultrasonography done previously, it was revealing that there was some macular hemorrhage. So after clearing the vitreous, we can see there is a fresh submacular subretinal bleed. So I am injecting just outside the arcade in multiple places actually. The blister formation. Because it was a very big submacular bleed, subretinal and submacular entered almost 3/4 fundus was almost 2/3 fundus was involved. In 3 places I actually injected and did air fluid exchange and SF6 gas with prone position. So post-op after this is post-op after 1 month. We can see there's pretty very good resolution, but I can see there's a RP rip, but it's away from the macula. So the vision ultimately came to 624, but I have given only one anti-VEGF. After that, patient has not come for follow-up. Maybe she will come with again one more episode of rebleed, because only one anti-VEGF was given, and I have not been able to give anti-VEGF. Then next case, this was a case of RAM. This was a case of bleed, RAM, pre-retinal bleed and subretinal bleed both. So this was small bleed, only intravitreal tPA plus gas could have also worked, but as there was a good amount of pre-retinal bleed, I decided to go for surgery with subretinal tPA. So after clearing the pre-retinal bleed, I am clearing this pre-retinal hemorrhage. So I can see the submacular bleed. Now see what happened. There will be blowout. I injected once. I thought I should inject once more. We can see. So I noticed there was a blowout. I didn't do ILM peeling and that setting. So in the follow-up, videos in the follow-up I found the full thickness macular hole. एक और वीडियो में 2A है ना इसका सर, आइकॉन कहाँ जा रहा है? 2A बस हाँ हाँ. In the follow-up there was a I had to do the vid lavage along with ILM peeling for the macular hole and put gas. Put C3F8 gas and prone positioning for 2 weeks. Did air fluid exchange and injected gas. So in the post-op say after 1 month, I can see the hole has closed and there is full resolution of the bleed, but there is some amount of edema in the paramacular area. The foveal contour is getting to maintain. So I am following it up. It is pretty good results. Case 3, this was a case of vasculitis. It was slightly unusual case. Vasculitis, I did angiography, peripheral huge CNP areas, vasculitis with submacular bleed. So I decided to go for the surgery. I am doing the vitrectomy. Doing laser for the periphery because there was a huge CNP areas. I had done the angiography previously, and then I am dealing with the submacular bleed. As the bleed was around that arcade only, I had to inject inside the arcade, but fortunately there was no blowout. and the blister occurring. Yes. And air fluid exchange. In the post-op, 1 month post-op, not 1 month, around 2 weeks post-op, is a very good resolution of the subretinal bleed and the gas bubble I can see. So I have done around 20-25 cases till now. This is one more case. I don't have the video, but and this is the post-op of that submacular bleed with the vasculitis. I can see the foveal contour maintained very well. These are some of the other patients. I don't have the videos of these patients. This is a big submacular bleed due to PCV. After single injection of subretinal tPA, I can see the resolution of the bleed with very good foveal contour. And this is one more patient with a very big submacular bleed. And in this case there was a RP rip, but it was away from the fovea, so the vision improved to 624. I managed to give 2 anti-VEGFs, and the patient has not followed up after that. This was one more. This was in my initial times. I was searching for cases. I think in this case only intravitreal tPA and gas would have been sufficient, but I did surgery, and the result was quite good. So in my limited experience, say for last 6 months, 8 months, I have done 25 cases. Not all cases have good results. These are mainly good results cases, and 1 or 2 cases have failed. There was one cases he developed more hemorrhage with hemorrhagic choroidal detachment after giving injection. I tried to do surgery, but I failed to do anything. And 2 or 3 cases needed vid lavage definitely after that in subretinal tPA. But all other cases are doing quite well.
Thank you, Dr. Subijay. I think we are running short of time, so we would like to finish this IC with the concluding talk of Dr. Devesh Kumawat, Assistant Professor, RP Center, AIMS. Over to you, Dr. Devesh.
Okay, thank you, Dr. Bibhuti, for the kind introduction. So I'll quickly take you to the cases here. 10-year-old male patient. This was the time when I was working at Kalavati Sharan Children Hospital, Delhi, which is affiliated with the Lady Hardinge Medical College. Patient had aplastic anemia, was awaiting bone marrow transplantation, and in the interim period was having blood transfusions. And the patient had developed diminution of vision in both the eyes for the last 3 months. Vision right eye was finger counting and left eye was finger counting 2 meters. Ultrasound in the right eye revealed vitreous hemorrhage along with submacular echoes suggestive of submacular bleed. And in the left eye, we had subhyaloid hemorrhage, submacular bleed, and intraretinal bleed. The photos are of the left eye. So after optimization of the hematological derangement, the patient was taken for pars plana vitrectomy in the right eye. The patient underwent PPV along with some macular injection of cocktail of RTPA and air hair, and followed by 20% SF6 for endotamponade. So here we are first removing the core vitreous, and after removal we see there are dense hemorrhages which are involving the retinal, the subretinal and the preretinal space. We have done the PVD, and now there is a thick sheet of ILM which is there, and we are peeling it off because it was very thick and adherent. And now using a 38 gauge needle we are injecting the drug. So first we have injected the tPA alone at this site, and the blab has formed. And then at its different site, now we are injecting the gas. And now as we see, the gas bubble has gone anteriorly. Now in this case, after FAX also it didn't come, at that time it didn't come posteriorly. We did FAX and then used 20% SF6 for endotamponade, and this is a 2 weeks follow-up. The vision was 3/60. Please excuse for the quality of the images because it was a 20-year-old fundus camera that was available, that was only available at that time. And this is at 6 weeks. The patient had vision of 4/60, and this is the OCT. The although we can make out the external limiting membrane continuous in that area, but hardly any ISOS junction or the ellipsoid zone is visible in that part. So the patient has 4/60 vision. Now, thereafter I shifted to RP center, and now we are grateful enough to have a compounding pharmacy there, ocular pharmacy, and the ocular pharmacy is compounding aliquates there. So Altiplace is being used, and of these two companies I have no financial interest, and aliquates are prepared in the dose of 0.2 milligram in 0.2 ml, that is 100 microgram in 0.1 ml, and then we dilute it further in the 1:10 ratio and achieve a 10 microgram in 0.1 ml of solution for injection. Now these aliquates are stored at -20 degree centigrades, and they are discarded at the end of 1 year. So this is a case 2, 61-year-old male patient with hypertension, diminution of vision for last 2 weeks, and there's a large area of submacular as well as pre-retinal hemorrhage, which is seen, and on OCT we can see the pre-retinal as well as intraretinal and subretinal hemorrhage, suggestive of a ruptured ram. FFA was also suggestive of peripheral as well as posterior ischemia, and there was delayed filling as well. So we took the patient for PPV with submacular injection. Here we used RTP as well as air again, and by the time we took the patient for the surgery, the bleed had dispersed further. So we removed the co-vitreous, induced the PVD, and now we can see this mound of submacular bleed which is there, and the sclerosed vessels anterior to it. Now with the 38 gauge needle, now we are injecting the drug. After injection of the drug, we could see the mound which is there, beautiful mound, and this is the air bubble which had moved initially anteriorly, but FAX it is again moving back to the posterior pole. So at 1 month post-op, the best corrected visual acuity was 1/60 only, because there was profound macular ischemia that we saw on the fluorescein angiography, and there was a residual film of submacular bleed which was still present, but still there was a tremendous decrease from the preoperative picture. Now case 3 is a 64-year-old male with diminution of vision for past 3 weeks with the subhyaloid as well as submacular hemorrhage. There was a breakthrough hemorrhage also, and in the left eye there were drusen along with RP changes. So here we used Avastin in addition to the tPA and air injection subretinal, and this is the surgical video. We have done the core vitrectomy. We are inducing the PVD using tricot. We have done that, and now using the 38 gauge needle, we are injecting the drug. We have injected the drug separately and the air separately. Now this air, there was initial resistance to inject, so we checked it outside, and then there was sudden release, and then we injected it into the subretinal space. And this was followed by fluid air exchange and again gas tamponade. So this is at 3 weeks. The bleed has come down heavily, and then you can see there is a fibrovascular PD which is there. Although there was no, till 6 weeks time, we could not find any further reoccurrence of any intraocular or intraretinal or subretinal fluid or activity of the CNVM. So the best corrected visual acuity in this patient was 3/60 at 6 weeks. Now this is the last case, 36-year-old male patient who had road traffic accident 4 weeks back. The patient had finger counting 1 meter vision, and so here we can see there is a old hemorrhage which is there, and there is a choroidal rupture which was passing through just temporal to the foveal area, and there was there was a fresh submacular hemorrhage as well. Now we could have gone for just a tPA injection as well as intravitreal anti-VEGF injection in this patient, but I thought that let's try submacular injection, thinking that it may affect the old bleed as well. It may lyse the old bleed and remove it as well. So here we injected RTPA and Avastin, and since I had an apprehension that it may blow out, there is a lot of fibrosis in the neighboring areas, so I decided not to inject air in this patient. So quickly going through the video. So after using the tricot, we have induced the PVD, remove the vitreous, and now we are injecting the drug, that is the RTPA as well as the Avastin, and a blab has formed. We have not injected air in this patient, and we can see the blab at the posterior pole at this area of the submacular hemorrhage, which is relatively fresh, and then we did the air fluid exchange. Unfortunately, the old bleed did not get lysed, but yes, the fresh bleed had got removed from, displaced from the macular center of the macular area, and there was still a CNVM scar which was present. Now the patient is under follow-up. So the key aspect that I consider for management is the size, the thickness, and the duration of the submacular hemorrhage. And yes, I have not tried the microdose injector. I have felt that yes, there is a sudden release of air that do happen, but I have noted out of 8 or 9 cases that I have done with intravitreal, with subretinal air, the blowout happened only in my first case, in the initial first case, and then I have been very careful and I injected slowly, but I have not had it in the last 7 or 8 cases that I have done using using subretinal air. But yes, a microdose injector is one thing that I'll look forward to, and for a more controlled injection. Thank you.
Fantastic talk, Dr. Devesh. One thing just I would like to add, that when you're in an institutional practice, you have pretty trained paramedical staff with you. Usually in a private setup or in a peripheral setup, you don't often have such trained staff. So you need to have such complicated, to undertake such complicated procedures in a private setup. You need to make it as assistant free or as assistant independent as possible. So that's also one of the aspects why I advocate the use of a microdosage injector. But fantastic cases and fantastic results. Thank you so much. Sir, please.
Minus 20 degrees.
For 1 year,
For 1 year. Now they made it last year. Now they are going to discard after 1 month.
20 degrees centigrade means
Minus
you are
20 degree.
minus 20 degrees centigrade means in the kind
There are
of
separate freezers for that.
freezers means deep freeze.
Deep freeze, yes sir. And then you thaw it. They ask us to thaw it for an hour before using it.
Okay. But generally we are reusing the this thing RTPA from a single vial. I'm just taking it out, just like Avastin, and keeping it there in the in the door, not within the in the deep fridge, but in the door at 4 degrees centigrade for maximum of 2 weeks.
So that is at
2 to
2
3
to 4
weeks.
degree, but this
2
is
to
at
4
minus
degree.
20.
Yes,
so
minus
that's why
20. Okay,
So
you can
that's
keep
why
it for.
we are able to store it at till 1 year.
Now, I was thinking maybe if you are not just if you are not reconstituting the alicot and if you are keeping it directly into the deep fridge, the whole vial, so can you keep it?
That could be done, but then that will have its, if you are going to pierce it multiple times, then the risk of infection will be there.
No, not multiple, 1 or 2 times.
So
First time I have
probably
used
it
it,
will.
second time. Then if you are like submacular hemorrhage, it will come within 1 week or within 2 weeks, maximum 1 or 2 patient will come.
Yes, sir.
So I can reuse it for
So
once
here we
more.
are preparing almost 50 to 60 allocates from a single.
Single.
50
That's
milligram
true
of
because
this thing.
most of the dose of the drug will be just get
will
us.
be discarded.
Hey, once you reconstitute, can you reuse it after 2 weeks?
Sir, it's mentioned in the brochures also
Ye-
that you
yes,
should
yes.
discard within a day. Matlab if you
Sir,
have used
8
it-
hours.
but
It says 8 hours.
8 hours. 8 hours. But I have used it, and even in the in our other forum also, I've discussed it. It is they are also using it
After
with.
reconstitution, you are using.
Yes.
but
Even
how
after
do we
2
check?
weeks.
Like we can check the action. Matlab
No, yes, it acts. It acts.
It
It
acts.
acts.
So, but
Yes,
how
yes,
do
yes.
we confirm that it has not been degraded to?
That is very difficult. You have to do the other studies also, like to.
So,
see
but
the
then
efficacy
in
of
that
drug.
case, sir, don't you
But
think
clinically, the efficacy is not gone, even after 2 weeks.
so but okay, but sir, I will have my apprehensions towards it just because if it,
No,
if
that
it
is
clearly states that it has to be used in 8 hours,
Actually, the brochure
then-
clearly states that it has to be discarded.
It should be discarded after 2 8 hours. Within 24 hours, you have to reuse it. But I have used it, and even our other colleagues also in multiple, not in our center, even from Delhi or other, whether they are using this RTPA.
Maybe it's just the company's
They can
proposal.
use.
Sir, I
Even
think,
Dr. Atul Kumar also, he has advised. me
sir,
to
I
do.
think, I mean, off the chart in my head, sir, I think instead of aliquoting, it basically comes in a powdered form. So how about we divide the powders into multiple forms and then reconstitute it as and when required?
That needs the proper sterile environment
Yeah, sure,
is
yeah.
available only in RPC. But is not available in our center or
But sort of
yours.
if we reconstitute it and then think of
Yes.
it, I mean, so
No,
if it
it works. It works nicely.
so because then the retreatment option gets very expensive both monetarily and psychologically to the patient if that
No,
thing
for a
doesn't.
poor patient, for the next poor patient who cannot afford our tPA, I can reuse it within 2 weeks, not beyond 2 weeks. Even
Right.
some people are using also after 1 month. Also.
Okay, sir.
Maybe the point you have raised that it can be stored in a deep freezer at -20 and then we can maybe use it maybe
Yes,
beyond 1 month
maybe.
also.
Maybe.
From Dr. T.
Okay. Yes.
So I think with that we come to the end of this IC, and I thank all the participants, speakers, and the audience to be a part of this. And we look forward to meeting you next year. Thank you so much.